Acute Lymphoblastic Leukemia Treatment, Understanding the Three Stages for Patients. Even though today's main topic is understanding the typical phases of ALL treatment, we know this is our very first event for the ALL community, so we're starting at the beginning. That's why we're especially grateful to be joined here by Dr. Hannah Levavi, an hematologist oncologist at the Icahn School of Medicine at Mount Sinai in New York, where she specializes in caring for adult leukemia patients. Dr. Levavi will help us build a strong foundation by explaining what ALL is, how it is diagnosed, and the different subtypes before walking us through the three main treatment phases. So once again, thank you, Dr. Levavi. Thank you so much for being here with us. We're honored to have kick off this first ALL session. And I'll now turn it over to you.
Thank you so much for that introduction. I'm going to share my slides. Do you see that okay?
Yes, they look perfect.
Okay, great. Thank you again so much for having me. My name again is Hannah Levavi. I'm an assistant professor of medicine at the Icahn School of Medicine at Mount Sinai Hospital and affiliated with the Tisch Cancer Institute there. And today I will be talking about acute lymphoblastic leukemia lymphoma, as you all know. I initially was asked to really focus on the phases of treatment, but I think that I expanded the talk a bit just to really be an introductory talk about this disease. And I will focus both on some background and then on how we treat this disease and some principles of therapy. So my objectives for this talk are for all of you to understand the definition and epidemiology of acute lymphoblastic leukemia lymphoma, which I'll from here on just refer to as ALL. Understand how ALL is diagnosed and classified. And then I would really like everybody to have some familiarity by the end about the principles of ALL therapy, including the phases of treatment, the types of regimens that you might come across, and how we're integrating novel therapies into the traditional chemotherapy backbones that we have been using for many years. And then I will just very, very briefly touch on some exciting advances because this is a field that's constantly changing and there are new things on the horizon all the time. So first to talk about the background in epidemiology. So at the very basics, the way we define acute lymphoblastic leukemia is that this is an aggressive blood cancer that can involve multiple parts of the body. Usually the blood is involved, the bone marrow, lymph nodes, and really many other organs can be involved. It arises from these early precursor cells that usually live in the bone marrow, and they develop abnormalities in the DNA within these early cells, in which we call cytogenetic and molecular abnormalities, depending on the type of abnormalities that occur. And these abnormalities impair the ability of these cells to mature and differentiate, grow up into the mature types of cells that then leave the bone marrow, leave the lymph nodes, and go to other parts of the body. And these cells don't undergo a normal life cycle, meaning that normally we have cells, blood cells that start off as stem cells. They mature in a very kind of predictable fashion. They leave the bone marrow, leave the lymph nodes, and then they do their job, and eventually they're able to die off. And one feature of leukemias and cancer in general really is that the normal life cycle gets disrupted, where these cells are able to live beyond their normal lifetime. They undergo constant replication and kind of take over. The terminology for this particular disease can be somewhat confusing, and I think you can see if you read about it on patient websites or in any of the literature. Sometimes it's called acute lymphoblastic leukemia, sometimes it's called lymphoblastic lymphoma, sometimes it's called, as I wrote up here, acute lymphoblastic leukemia / lymphoma. And so just to get the nuances of those definitions out of the way acute lymphoblastic leukemia is generally defined is when there's more than or equal to 25% of these abnormal leukemia cells, which we call blasts, in the blood or the bone marrow. Sometimes this disease presents with more of what we call a lymphomatous presentation, where there's less disease in the blood and the bone marrow and more disease outside of the blood and the bone marrow. For instance, with T-cell acute lymphoblastic leukemia, often patients present with a large mass in the chest that we call a mediastinal mass, but they may not have a great deal of disease or really any disease in the blood or the bone marrow. And so we call that lymphoblastic lymphoma. Many of the principles of treatment are the same. There are some small differences in responses to particular therapies that oncologists might talk about. But really, we think of this disease as sitting on a spectrum between leukemia and lymphoma, depending on the patient. And so when I mention that these are diseases that arise from these early precursor cells, what I'm talking about is this kind of maturation tree that we think about in hematology. We have these stem cells that we call hematopoietic stem cells that live in our bone marrow, and they start to branch off into different subtypes of cells as they divide. The first branching point branches to either myeloid stem cells or lymphoid stem cells. Diseases that arise from these myeloid stem cells are a different category of diseases, but can include things like acute myeloid leukemia or AML, which is the most common type of acute leukemia. When we see ALL, it arises from this lymphoid stem cell, which is the other branching point. And this is where the point at which abnormalities develop in the cells and they turn into these leukemia cells. So I just want to bring this up. This is more something that medical students and physicians think about, not so much patients, but when you hear about people who have other types of leukemia, this is sort of the initial way that we define ALL compared to those other leukemias. ALL has a really interesting epidemiology and has very interesting patterns in who it affects. So overall, this is considered a rare disease. It's only 0.3% of all cancers in the United States. And although that's a very small number, it is the second most common acute leukemia after AML. AML is much more common, about 80% of acute leukemias, whereas ALL is about 20%. About every year we see somewhere between 6,000 or 6,500 new cases in the United States. And you can see here on these curves from the SEER database, which collects national cancer information, that the incidence, meaning the number of new diagnoses each year, is increasing somewhat over time. It's really not clear why that is, whether it's because we're diagnosing it better or whether there are some environmental factors that are actually increasing the number of cases that we're seeing, or whether there are population changes and more patients or more people here who have some sort of predisposition. But there are more cases now as of at least 2022, when this data was last collected, than there were back in the 90s when we see the graph start here. When I see new patients, one of the first questions that I get asked is, why did I get this disease? What did I do, or what exposure did I have in the past that might have predisposed me to getting this type of leukemia? So we know that there are some things that can happen in one's life that can predispose them to developing blood cancers in general and ALL in particular. Those things can include prior chemotherapy. So we know that patients who've had cancers in the past that were treated with particular types of chemotherapy that work by disrupting DNA, those chemotherapies can disrupt the DNA in the bone marrow cells, those stem cells, and then later on in life give rise to acute leukemias. And so we do see some of these secondary leukemias where it was secondary to some chemotherapy or radiation. There are certain environmental toxins that people are sometimes exposed to, including solvents and other chemicals, that can cause all sorts of cancers, including ALL. And there are genetic predispositions. So there are several different uh, cancer predisposition syndromes that sometimes are diagnosed in childhood, sometimes not, that do predispose to ALL. One of the more common ones in the pediatric population is trisomy 21, or better known as Down syndrome. We know that patients with Down syndrome are more likely to develop ALL than the general population. And then we know that there are other rare conditions that have other syndromic features that include a predisposition to ALL. But I will say that most patients really don't have any known risk factors. And it's really hard for people to understand that, because I think there's a comfort in thinking that there was something identifiable that predisposed you to getting a diagnosis like this. It makes us all feel like we are in more control of the things that happen to us. But really, in most patients, we cannot identify any sort of workplace exposures or prior treatment, medical treatments or genetic predispositions. And so for the most part, we really don't know why one person develops this disease and another one doesn't. We do know that there are certain subpopulations that do, in general, have more cases of ALL, and among the Hispanic population, there really is a higher incidence of this disease. So I work in an area of Manhattan where we do have a very large Hispanic population, and a lot of my patients have some sort of Hispanic ethnicity. Some of them are immigrants from Central and South America. Some of them have been here for many years, but their ancestry comes from certain parts of the world. And it's not exactly clear why patients of Hispanic descent have a predisposition to ALL or a higher incidence of ALL. But there are thoughts that there are particular genetic differences in that population that might predispose them. And that's an area of research that is continuing. We know, though, that these patients are diagnosed at an earlier age. At least adults with ALL who are Hispanic are diagnosed earlier than white adults or other race and ethnic groups. And then we know that there is this increased incidence. And in general, there has been a trend toward a poorer OS, means overall survival. So among Hispanic patients compared to non-Hispanic white patients, there has been this trend toward a poorer overall survival. And there's been a lot of work that we've done to see whether this is because of access to treatment and other socioeconomic factors or related to disease characteristics. And we know that there are some higher risk disease subtypes that are more common among Hispanic patients. And so it's probably some interplay between those factors. I think a lot of people, when they hear ALL, and even among physicians, they think of it as a childhood disease. And it is in some ways. If you look at this graph of the new cases of ALL by age group, you can see that just over half of the new cases are in patients who are younger than 20. And this is the most common cancer among pediatric patients, among children and adolescents. However, although about half occurs in patients younger than 20, we do see that other half of these cases occur among patients across the entire age spectrum. So it's a particularly interesting disease to treat because it really affects patients at all ages. So here you can see the median age at diagnosis, meaning that if you take everybody diagnosed with ALL and you put them in a straight line right in the middle, the middle person will be 17 years old. So it really does skew much younger than other types of leukemia like AML, where the median age is in one's 60s. But although it is a disease that has a tendency toward younger patients, the median age at death is 60 years old. And this has many reasons as well. We've had enormous successes in treating ALL in children, and it really, for most kids, is thankfully a very, very curable disease. Um, in adults, we've had a harder time achieving those cure rates, though I will say that there have been really a lot of successes in recent years, and we're closing that gap between adults and children. But we do know that we have a long way to go. So a little bit about how we diagnose this disease, how we classify it, and how we risk stratify patients. So the initial symptoms of ALL can be really variable. We do always have a few patients every year who are diagnosed based on routine blood work that shows some abnormality in their blood counts, and then they're referred to hematologists and get this diagnosis. But a lot of times people present with cytopenias, meaning low blood counts, and the symptoms from low blood counts. So what happens in ALL and really all acute leukemias is that you get this infiltration of the bone marrow with these rapidly dividing leukemia cells. And I always explain to patients that the bone marrow is the factory for all of your blood cells. This is where all of your blood cells are developed and grow up into adult blood cells that leave the bone marrow. And when you get these rapidly dividing leukemia cells that completely take over the bone marrow, you develop cytopenias where the other blood counts that are the other blood cells that are not leukemia cells all go down because the bone marrow only has so much space and you aren't able to make your other healthy blood cells in a normal fashion. And so this results in things like anemia, meaning low red blood cells. When people are anemic, they feel tired, they feel short of breath. Sometimes they develop palpitations because their heart is really working hard to pump the little bit of red blood cells that are available to the entire body to deliver oxygen. People develop thrombocytopenia, meaning low platelets. So our platelets are responsible for preventing bleeding. And, oh, sorry, I switched this around. But when people have low platelets, they develop bleeding and bruising, and that can be anything from increased bruising on the extremities, even when people aren't, hitting themselves on furniture or falling. They just develop spontaneous bruising. Sometimes people develop this type of rash called petechiae, where they see little pinpoint red spots all over their body from the low platelets and these tiny little mini hemorrhages that occur beneath the skin. And sometimes people can have much more significant bleeding, nosebleeds that won't stop, blood in their stool, or even bleeding in the brain, which is our most severe type of bleeding. And then when people don't have enough space in their bone marrow to make their white blood cells, they develop neutropenia, meaning that these really important white blood cells called neutrophils are very, very low, and they become at risk for all sorts of infections. Usually, not everybody presents initially with an infection, but people are more likely to develop infections like anybody else, and also rarer infections like fungal infections that general healthy patients really don't get. There are many other symptoms that people might develop. So fevers, night sweats, and unintentional weight loss can occur. These sometimes go on for weeks or even up to, a month or a couple months before somebody presents for care. Because, as I mentioned before, ALL occurs on the spectrum between leukemia and lymphoma, we do see that these people sometimes present with large lymph nodes, and those lymph nodes can be anywhere. They can be in the neck, they can be in the groin, they can be in the armpits. And then we do see with ALL that there is this phenomenon of extramedullary infiltration. So extramedullary means outside of the bone marrow. These cells end up going very frequently to other places in the body, and sometimes those are the first symptoms that people have. So people can get gum swelling, which we call gingival hyperplasia because the cells start to infiltrate the gums. ALL in particular, different from AML, the other more common type of leukemia, it really has this proclivity to go to the central nervous system. So these cells have developed ways to inhabit the cerebrospinal fluid around the brain and get across the blood-brain barrier. And so people sometimes develop headaches or confusion or other symptoms of leukemia going to the brain. And this becomes important in how we treat patients with ALL. And sometimes people can even have skin involvement with leukemia cells going under the skin and causing a rash that we call leukemia cutis. It's very rare, but we do see it. So how do we diagnose ALL? The most important test that we do at initial diagnosis is a bone marrow biopsy and aspirate. And this is something that we do for a lot of blood cancers. As I mentioned, the bone marrow is the factory for all of our cells, and we're able to get the most information that we can from the bone marrow itself. And so the way we do bone marrow biopsies is we have people lie down either on their side or on their stomach, and we numb the area right above this bone that's close to the surface of the skin called the iliac crest. We numb the skin, we numb all the way up to the bone. We put a needle in, and then we pull something called an aspirate, which is the liquid portion of the bone marrow. And then we go in a little bit deeper and we remove a very small little core of the bone marrow. So I usually think of it as if you took a drinking straw and thought of the diameter being about half the diameter of a drinking straw and about one or 2 centimeters long. That's about how much of the actual bone marrow that we're actually taking out. And this is a really, really important test. We get information by looking at the morphology of the cells in the bone marrow and that aspirate, that liquid portion. So that means that we stain the actual bone marrow and the slides that we make from the aspirate. So we put a little drop of the bone marrow and make a microscope slide out of it. And we can actually see the cells under the microscope and get a lot of information about how much of the bone marrow is involved with the ALL. Sometimes we can get a clue as to whether this is ALL or AML just from looking at it under a microscope. And then we also do all sorts of special stains to see what type of cells these are. And that can help us determine, is this ALL or AML or some completely different disease? Is this, does this person's disease have certain proteins on the surface of the cells that tell us something about how the disease might behave, and also what types of treatments, what types of targeted treatments we might be able to use. We also do a test called flow cytometry, where this is another more sophisticated test that I won't go into in a lot of detail, but it also helps us characterize these cells, determine what kinds of proteins are on the surface of the cells that can help us guide our diagnosis and our treatments. And then we do cytogenetics. This is an array of different tests that allow us to actually look at the DNA inside of these leukemia cells. And so this is an example of a karyotype where we take out we're able to actually visualize the DNA in these cells. And these are, each line over here is a different chromosome, which is how the DNA is organized in our cells. And we're able to count do these leukemia cells have normal numbers of chromosomes? Are there abnormalities where one piece of a chromosome is displaced onto another chromosome where it shouldn't be? And all of that information really helps us understand someone's disease. And now we do something called next generation sequencing on all of our patients. Next generation sequencing is a very sophisticated test where we're actually sequencing the DNA inside of these cells and looking for teeny tiny submicroscopic abnormalities that, again, can help us risk stratify patients and also sometimes help us determine whether they're eligible for particular treatments. We also do imaging on all patients with new ALL. So some of our imaging is guided only by symptoms, but at least at my institution and at most institutions and most guidelines recommend that we do some CT scans or PET scans at initial diagnosis to see, are there a lot of lymph nodes involved? Does this patient have a big mediastinal mass? Like I mentioned before, some patients develop where they have a big mass right in the chest. And this helps us understand where the disease is at diagnosis, and then later on we can understand if we've eradicated all of the disease that's outside the bone marrow. In some patients who have uh, central nervous system involvement or signs of central nervous system involvement at diagnosis, we also sometimes do imaging of their brain. And one unique thing about this disease is that in men, it does have a tendency to involve the testes. So everybody, every male with a new diagnosis of ALL needs to have a testicular exam. And if there's lack of clarity or if there's any finding on testicular exam, we also will do a scrotal ultrasound to characterize whether there's disease there. And as I mentioned before, because this disease does have a tendency to go into the cerebrospinal fluid around the spine and around the brain, everybody with ALL gets a lumbar puncture at diagnosis, which means that we put a needle into the spine and remove cerebrospinal fluid, and we test it for the presence of leukemia. And then we're also able to treat that area with chemotherapy by then injecting chemotherapy into the spine. And we do this to treat diseases if it's there, but also everybody, no matter whether the disease has infiltrated the cerebrospinal fluid or not, everybody really does need prophylaxis, preventive chemotherapy injected to the spine. And depending on which chemo regimen or treatment regimen patients are on, we do different numbers of these lumbar punctures throughout treatment and use different chemotherapies. So in terms of how we classify ALL, this is a very simplified version, but I think it's important for patients to understand. So one of the big branching off points once we have determined that somebody has ALL and not AML or some other blood cancer is whether this is a B-cell ALL or a T-cell ALL. And these are both referring to different types of immune cells that we all have. But whether or not the ALL arose from a precursor B cell versus a T cell is really important in terms of what therapies they might respond to and certain prognostic classifications. Especially when somebody has B cell ALL, we always want to know, are they pH positive or pH negative? And pH here refers to this abnormality that we sometimes see in patients with ALL. Called the Philadelphia chromosome. It's an abnormality where one piece of the DNA is bound to another piece of the DNA where it really shouldn't, these two pieces should not be next to each other. And it results in something called the Philadelphia chromosome, a translocation between these two pieces of the DNA that drive the disease in these patients. So people who have pH positive disease, nowadays we integrate targeted therapy for all of these patients. And it's really important to know whether a patient has that Philadelphia chromosome. And that testing that I mentioned before when I discussed the bone marrow biopsy, we always test for the Philadelphia chromosome in these patients, and we never start treatment before knowing the presence or absence of the Philadelphia chromosome. In people who are pH negative, there's also this subcategory of pH-like ALL and non-pH-like ALL. These are patients who have some similarities with pH positive patients, but they don't actually have that particular Philadelphia chromosome. And I'll talk about that a little bit next or later on. And people who have T-cell ALL, the categories are a little bit less detailed, but the one category that's really important to know is whether a patient has this entity called early T precursor ALL. This is a subcategory of T-cell ALL that has particular behaviors and particular ways that we risk stratify these patients. So it's really important to diagnose this, and it's sometimes a hard diagnosis to make. So it's really important with all of this to make sure that anybody who has a diagnosis of ALL is being treated at a center where they treat a lot of ALL, where the pathologists who are reviewing the studies have a lot of experience making this diagnosis, because sometimes this is underdiagnosed because the correct stains on the bone marrow aren't always sent. And then I won't belabor this much, but there is this category of a mixed phenotype acute leukemia where people can have features of B cell and T cell ALL, or T cell ALL with a myeloid, like an AML type appearance, or B cell with a myeloid appearance. And these patients are a rare entity, though we do see a good amount of it, and they should be treated with understanding of how patients with this MPAL or mixed phenotype leukemia tend to respond. This is just to point out how much has changed since we started classifying acute leukemia. So back in the 1970s, there were really three categories of ALL, and this was all based on how the cells looked under the microscope, and a few notes about the types of surface proteins that are expressed on the cells. But it was a very, very simplified categorization. And now we have multiple competing organizations that are trying to really hone down the differences between individuals' diseases. And you can see here, the World Health Organization in 2022 came out with updated classifications of ALL. And we have, numerous types of B cell ALL and T cell ALL, really, that ETP, or early T precursor ALL, is pointed out, but this is much more expansive than in the 1970s. And now there's also this group called the International Consensus Classification, and they in 2022 also came out with their own set of different subcategories and these are mostly, as opposed to the 1970s, where really we didn't have a lot of techniques to differentiate types of leukemia. We were only looking under the microscope and a little bit at the types of proteins on the surface of the cells. Now we're looking at all these complex details of the DNA abnormalities within one's leukemia to subclassify them. And I'm sure this will all be different as time goes on. We understand the disease more. So there are a number of different prognostic factors involved in how we group patients with ALL. So we know that as patients get older, age does have an impact on how well people respond to treatment. We know that one's performance status, so how strong somebody is, we think very differently about somebody who is a 65-year-old who's working and active and able to, do all of their functions independently, compared to 65-year-olds we know who have heart disease and diabetes and wheelchair bound. All of that goes into how we treat patients. We know that the elevation of the white blood cells at diagnosis also has a prognostic effect. So in T-ALL, when the white blood cell count is over 100,000 at diagnosis, and B-cell ALL, if it's over 30,000 at diagnosis, those tend to be higher risk. And then whether or not somebody has disease in the brain already at diagnosis can impact prognosis. And these were really the age, white blood cell count, and the presence of disease in the central nervous system were the main ways we used to risk stratify patients. But now we have a lot more information to risk stratify patients based on the subtype of ALL, what kinds of abnormalities they have in the cells, what kind of DNA abnormalities they have, and then also how their disease is responding. And we know that the people who respond with very, very deep remissions very early on do better. And we'll talk a little bit about what that means a little later on. And so this is just an example of how cytogenetics, some of those characteristics of the DNA can affect prognosis. So here, patients who are categorized as standard or as a high risk here, or very high risk, in orange and red here, these patients had the highest relapse risks and also the lowest event-free survival and overall survival compared to patients who had standard risk ALL. And then this pH-like category that I alluded to before, we know from numerous studies that these patients who have this particular abnormality involving a gene called CRLF2, they tend to have a poor overall survival. So that's this line in blue compared to people who are not pH-like in this particular study. And then over here, we can see that the survival in this study also for the people with this CRLF2 abnormality was much lower than patients in other categories. And I mentioned before that the disease kinetics, how the disease responds to initial treatments really matters a lot in how we treat patients nowadays and also how we expect the prognosis to be. So I want to mention this concept of measurable residual disease. So after somebody gets treatment, we always do a bone marrow biopsy after their first phase of treatment, and we do many bone marrow biopsies after that. And we think about how much disease is still there, sort of like an iceberg. So here, if this is the water line. If somebody has very obvious disease that we can just see under a microscope, we call that like presence of morphologic disease. And so that means that the disease is very, very obvious. It's, well above the surface. We can very easily detect it with very simple techniques. But now we also have techniques where we can detect the presence of disease even if we can't see it under the microscope. And we call that measurable residual disease, or MRD. And so there are techniques using flow cytometry where we can see disease even one cell out of 10,000 cells that are investigated. We can detect that level of sensitivity of residual disease after somebody's received treatment. We know that people who have no MRD by this measure, flow cytometry after treatment, have better outcomes than the patients who do have residual disease. And now we even have techniques where we can see if somebody has even one leukemia cell out of 1 million cells that are evaluated. And there's a particular company called Adaptive that has an assay called clonoSEQ that is approved, FDA approved, to look for this level of sensitivity. And so we can even see if somebody has one cell out of 1 million still detected. And below that, we really don't have reliable assays, but we do know that all of this has a lot of importance in prognosis. And this is an older study now, but this is a large meta-analysis looking at the importance of MRD. So here we can see that patients who had no MRD had better event-free survival, and they had better overall survival than the patients who had measurable residual disease. And then this is a much more recent study that says, basically the same thing, but looking, using that much more sensitive 1 in 1 million assay. We know that patients who were MRD negative, meaning with all the fancy techniques that we have, they did not have detectable disease. They did much better if they compared to the people who did have measurable residual disease. So here, after one cycle of treatment, at 3 months, at 6 months, no matter when you test for MRD, the patients who were negative for that residual disease did better than the patients who had these small amounts of disease. So this is really integrated in our decision-making for all of our patients. So I know I'm going a little over, but I did want to talk about some principles of ALL therapy. And please stop me if I'm going too over and you want me to wrap up, Mary Lou.
No, go ahead. Go ahead.
Okay. So ALL really is a poster child for this concept of multi-agent chemotherapy, where we combine different types of treatments, chemotherapy, other therapies with different mechanisms of action in order to target the disease from multiple angles and try to avoid resistance. And because of that, the regimens can be really, really, really complicated, which is a headache for the patients, a headache for the providers, and really, I want to drive home the importance of being treated at a place that has experience with this because these regimens are really complicated. And it also is a poster child for this principle in all of oncology of these phases of treatment, including induction, consolidation, and maintenance. And I'll define those and go through that a little bit more. In ALL, we give CNS prophylaxis to all patients. So as I mentioned, we test the cerebrospinal fluid and then treat the cerebrospinal fluid, even in patients who don't have detectable disease there. And we know from many decades of experience that this prevents relapses in the CNS and improves survival. We use this concept of MRD-based risk stratification that I talked about. And then we also use supportive treatments for all patients. So patients generally need transfusions, and we give prophylaxis, preventive anti-infective agents like antibiotics and antifungals to patients, especially in their most immunocompromised portions of the treatment. So this is an example of the multi-agent chemotherapies that we use. So this comes from some principles of pediatric ALL therapy, where we risk stratify patients as either standard risk or high risk. And then we give an induction with 3 drugs or 4 drugs. We give this consolidation phase, which integrates oral medications in addition to IV medications. We have this interim maintenance, delayed intensification, and then a long multi-year maintenance. And each of these phases includes numerous different chemotherapies. And I put this picture down here of kids with now I'm forgetting the word, but a parachute, playing with parachutes, because when I first was learning about ALL and I was looking through these regimens, I imagined that a bunch of doctors threw pills and chemotherapy onto a parachute and had some kids, wave it up and down and let it fall where it fell. And then they were like, okay, that looks like a regimen. Because sometimes looking at these regimens, it can really look like that, like some random assortment of chemotherapies that somebody, sadistically decided to segregate into these phases. But really, there is rationale for how we use these different drugs, the order of drugs, and how these therapies and these phases developed. And so this is an example of this thing called the BFM backbone. This is a German backbone chemotherapy that now is the kind of the what do I say? I guess backbone is the best word I can think of, but it's the backbone for many different and most pediatric trials, and also in the pediatric inspired regimens that we use for adults. So first we start with this induction phase. Most induction phases using a BFM backbone are about 4 weeks. And this is intensive chemotherapy. And the goal of this is to induce a remission. So we start with somebody who has a very high burden of disease. There's lots of disease in the bone marrow or the blood or the lymph nodes. And then our goal is to very rapidly induce a remission. And a remission means that we want to get to a point where there's less than 5% leukemia cells in the bone marrow and no detectable leukemia outside the bone marrow. And so back a long time ago, that initial phase was not as intense as we do now, but we know that inducing a rapid remission is really important to attaining the best successes. And then after that, we go into this consolidation phase. And this consolidation phase is around 8 weeks using this type of backbone chemotherapy, where we're integrating both oral and IV chemotherapy, as well as that prophylactic intrathecal chemotherapy into the spine. And this is, again, a very intensive phase of treatment where we've already induced this remission, but we're trying to rapidly deepen that remission. So let's say somebody got into a remission, but they still have detectable, measurable residual disease. We want to get that down as much as possible to 0. And then after that, we do something nice by giving this thing called interim maintenance, where it's a bit of a break. Initially, when this backbone was developed, they started with an induction, and then they added this consolidation. And then they realized that if you intensify, again, using some combination of induction and consolidation, they had good outcomes, but it was too much to go from these two intensive phases into this another intensive phase. So we do this thing called interim maintenance, where it's a little bit gentler. People recover, they feel a bit better, and then we do a bit more intensive chemotherapy for another 8 weeks. And then very importantly, we go on to this maintenance phase. And this maintenance phase can be anywhere from 2 to 3 years, or sometimes a little bit less with some more contemporary regimens. And this maintenance phase is intended to prevent relapses during those first years when relapses are most common. And so here I just defined, I think I spoke about all of these details, but these are just how we define these phases. And so all that BFM backbone really comes from pediatric trials. And so it was initiated in BFM stands for Brooklyn, Franklin, Munster. So this was a German concept that was now integrated into most of the COG trials that are in the United States. There was a very pivotal trial in 2000 that was published in 2019 by Wendy Stock at University of Chicago, where they looked at using this concept of these pediatric-inspired regimens and applying it to adults and seeing if we could improve the survival of adults with ALL by applying these principles. And so they used a BFM backbone using these high cumulative doses of chemotherapies, but at doses that were not as myelosuppressive, not as suppressive to the bone marrow as some of our other regimens, with this intensive, prolonged prophylaxis of the central nervous system, and then this long maintenance, and really trying hard to keep patients adherent. And we did see that compared to historical controls, there was a really remarkable survival. So this was a phase 2 trial, meaning that there was no comparator arm, but they did compare it to historical controls, and the overall survival was much better. And then this is just to drive home how complicated these regimens are. These are all the chemotherapies and the doses that are involved in this trial. However, that is really not the main regimen that you might see if you're being treated in the community. So hyper-CVAD was developed, I'm forgetting what year, but this came out of MD Anderson, which is a major cancer center, and they do a lot of amazing trials. And this is a much simpler intensive regimen that is not considered a pediatric-inspired regimen, that is the most common regimen that's used for ALL, and still an effective one, especially with more contemporary modifications where we're integrating other more newer therapies into it. But it's an alternating chemotherapy with something called hyper-CVAD, and then these two other drugs in the orange bars, and then this long maintenance phase. And so many people will probably be familiar or have heard of hyper-CVAD. And it's still not clear whether the modified hyper-CVAD regimens with the novel agents that I'll talk about in a little bit is better than or the same as the pediatric-inspired regimens that I mentioned. But there was a recent meta-analysis that tried to compare it, and they did see that in patients who are, young adults or, usually less than 40, who got the pediatric-inspired regimen, there was a trend toward improved survival in these patients. But the jury is still out, and there's a lot of discussion and debate about this. And then I'll go through these slides quickly about the novel therapies, but I think this is really important. Now we really have a lot of improvements from just chemotherapy that we used to give to patients. So in people with that Ph positive ALL, everybody is now receiving tyrosine kinase inhibitors. These are targeted therapies against that gene fusion that I tried to point out here that drives disease in people with this Philadelphia chromosome. And these are oral medications that have improved remission rates and also allowed us to de-intensify the chemotherapy for these patients. And there's a question, this used to be considered a high-risk subtype of ALL, and now it's actually classified, most patients are classified as having standard risk ALL if they have Ph positive ALL. There's a question of whether these patients need to have a transplant eventually, which used to be the standard for all Ph positive ALL. So the integration of these oral drugs into Ph positive ALL has really completely changed how we think of this disease. And then there are novel antibodies that are being integrated frontline and in the relapse setting. So one of them, rituximab, I won't talk about too much, but inotuzumab is something called an antibody drug conjugate, where it's an antibody that's developed and it's linked to a chemotherapy agent. It gets engulfed by the cell, and then that chemotherapy gets brought into the nucleus of the cell and starts to destroy the DNA in there. And this is something that is now integrated frontline in older adults. Sometimes we still use it in relapsed patients, and even in people who have just MRD positivity sometimes. And then blinatumomab is another groundbreaking drug. This is a bispecific T-cell engager. So it takes components of two antibodies, one that binds to the leukemia cell and the other one that binds to T cells in our own immune system. And it allows that T cell to recognize and kill the leukemia cell. So it's really a way for us to harness our own immune system to kill the leukemia. And now it's approved for relapsed patients, for people with just MRD positivity that we can't get rid of, and even for people who are MRD negative as a way to consolidate their remission. I won't talk about this, but this is one example of how we're integrating blinatumomab and inotuzumab up front. And this was an MD Anderson trial that showed that 100% of patients went into remission using a hyper CVAD backbone and integrating the novel agents. And then almost all of them were also MRD negative. This is an example of how we're modifying the hyper CVAD backbone and integrating inotuzumab with or without blinatumomab for older adults. So this, older adults are some of the hardest to treat because of their tolerance to chemotherapy, the cytogenetic subtypes of ALL, but the outcomes are pretty favorable using this regimen in older adults. And then this was a very recent trial that received a lot of press for good reason, where in pediatric patients who are age 1 to 10, they randomly assigned them to receive blinatumomab or chemotherapy after their induction. And you can see here that there was an improvement in survival in patients who received the blinatumomab in this red line compared to the people who only got continued chemotherapy. So this is a great example of how we're integrating blinatumomab in the front line. So not just in relapse, but for people who are having a favorable response to their initial chemotherapy, we're giving them blinatumomab with really good outcomes, whether they're at average risk or higher risk for relapse. And then in the adult population, we also have another trial that got a lot of press in the last couple of years called the E1910 trial, where they again integrated blinatumomab in consolidation for people who didn't even have any detectable disease after receiving a couple courses of chemotherapy. And integrating this blinatumomab resulted in a markedly improved overall survival. And especially in patients who are less than 55, we see that the survival is really much improved. And this comes from an abstract that's being presented this weekend at the European Hematology Association. So this is very new subgroup analysis. And so we're really identifying that we can improve outcomes using these novel therapies. In Ph positive ALL, it's gone as far as a point where we're eradicating chemotherapy completely from the regimens and just using a tyrosine kinase inhibitor with blinatumomab, like these two trials did. We're seeing really incredible survival in a subgroup of patients, these Ph positive patients who used to be considered very, very high risk. And then finally, just to point at some future directions, I didn't talk at all about CAR T-cell therapy, which I think a lot of you might be interested in, but just for time's sake, I didn't delve into it. But we have a number of CD19 targeted CAR T cell therapies for people who are CD19 positive on the surface of their cells. These are all FDA approved, and we're in the process of also developing modifications to these CD19 CAR T cells, dual targeted CAR T cells. So that type of cellular therapy is really going to be expanded, I think, in the future, and bringing these CAR T cell therapies in the front line, probably. We're learning about different combinations of tyrosine kinase inhibitors and newer tyrosine kinase inhibitors, targeting new pathways, including a pathway called BCL2. We're modifying blinatumomab to make it easier to administer, and then really refining risk stratification to figure out, are there even people who don't need as intensive therapy as we've been giving them, and which patients do need more intensive therapy? So that's where I'll leave off. And thank you all for listening. And thank you to all my colleagues who help me treat patients and figure out this world. And thank you to all of you and to all of our patients and their families.
Whoa, that was amazing. Thank you. Thank you a lot. I'm so glad that you started at the very bottom of everything that make things easier to understand as you go up. So thank you a lot for that presentation. I think we all walk away here with much better understanding of ALL and how treatment works. So thank you. And now we're ready to open up the space for questions. So if you're watching on YouTube, feel free to jump into Zoom or type them there in the chat, and we'll be watching those questions coming in. And since this is the very first event for the ALL community, I would love to take a moment just to share how we typically run our Q&A session. So we truly welcome all your questions. This is a space to learn and connect, and at the same time, get to know each other a little bit better and to understand this topic better as well. And we know how important your unique case is, but Dr. Levavi will not be able to share like any type of medical advice. However, feel free to ask any questions about this topic. If your question feels very individualized, I might reword it a bit so everyone in the room can feel helped with that question. So with that in mind, feel free to start sending your questions away. I do have a few that I want to ask first. So earlier in your presentation, you touched on how the age of diagnosis in ALL can be very different from children to teens to adults. That made me think of questions that many patients or families might have. So if it's the same disease, why can treatment look so different depending on the patient's age? Could you help us understand a little bit of why treatment decisions are different from very sides of this disease?
Yeah, that's a great question. So, while it is the same disease, meaning that we call it all ALL, now that we have these refined categories of disease, I would say that the disease is not exactly the same. So it is very biologically different when you have ALL in childhood versus adulthood. And we see that with differences in the cytogenetics and molecular abnormalities in the disease. So for instance, Ph positive ALL that I pointed out a little bit during my talk, that's about overall for all comers, it's about 20% of all ALL, or like 15 to 20% of all ALL. But in older adults, it's actually about 50% of ALL. So it's a really something that we see much more commonly in older patients. And so those patients have disease that actually behaves very differently than pediatric ALL. And then if you look at lots of different abnormalities, including something called KMT2A. So this is something I didn't point out in my talk, but kind of a hot topic right now. KMT2A rearrangements are very common in infant ALL. So in babies who develop ALL less than 1 year old, it's a very common abnormality that drives the disease. And that is under 1 year old is actually another very high risk age, in part because of those KMT2A rearrangements that we see. The positive thing about this, though, is that now we have an approved drug called a menin inhibitor. The drug is revumenib, and we have several other menin inhibitors that are under investigation currently and likely will be FDA approved in the future. And so we have targeted agents for patients with that KMT2A rearrangement. But I would say that KMT2A rearranged ALL is very different from Ph positive ALL, which is very different from, other subtypes of ALL with different genetic drivers. So that's one part of it. The other part is that, kids and adults, their biology is very different, independent of the disease. And so adults don't tolerate the same types of therapies that kids do, because adults have, often come with impaired organ function, other comorbidities, heart disease, diabetes, high blood pressure. So the patients themselves are very different, even if the disease is the same. And so one example of this is a drug called pegosparaginase that's integrated into the BFM backbone that I discussed. Pegosparaginase is a really powerful drug in ALL, and most trials using it really restrict it to younger patients. It initially was only used in children. In that trial I talked about using pediatric inspired regimens in adults, it was only patients 39 and under who were given that drug. And we know that as you integrate that drug into older adults, that the toxicity of the drug goes up. However, I will say that when used with dose reductions, we at our institution and at several other institutions have seen that we can safely administer it in older adults, but we do have to just be cognizant of the side effects that are more prominent as people get older.
Thank you. That makes things clear and look in a different perspective. So thank you. I have another question. What are the most important things that patients or families should know at the beginning of treatment? Are they key questions they should be asking at each different stage of treatment?
So I think that number one, and I emphasize this a couple times, I think it's really, really important to be treated at an institution that has experience treating these diseases. And at an institution that has experience with drugs like blinatumomab, inotuzumab, the newer tyrosine kinase inhibitors, if you're Ph positive. This is a rare disease, and while most hematologists and oncologists have seen ALL in their training, it really takes a long time to become familiar with these very complicated regimens and the nuances of diagnosing and treating this disease. So I would definitely encourage patients to at least get a second opinion from academic medical center that has, will be open, because it's always good to have some access to those trials, either at the outset or in case the disease comes back. I think the other thing I would become familiar with is this concept of MRD. It really is crucial to how we make treatment decisions for patients. And I would want to make sure that any place where, a patient of mine or a loved one were treated is using the most sensitive MRD assays in their patients. And that requires, I didn't go into the details of how we established MRD in patients, but it requires that at diagnosis, you actually are tested for abnormalities on the cells that then can be tracked to use that clonoSEQ assay. And so you want to be treated at a place that is going to do that work up front. If you're not and you switch to another institution, there are ways that we can get the samples and then, establish a tracking sequence for patients. But you want to make sure that they're thinking about the disease with these most cutting edge technologies. And then I would also want to make sure that the place where I'm being treated either has CAR T-cell therapies at that institution, or has a good referral relationship with an institution that's using CAR T-cell therapies.
Thank you. And I think I
Mhm.
have a last one to close our event. Sometimes patients worry a lot when they hear about treatments and they think they need to be all the time at the hospitals. And you mentioned each regimen and all the weeks. So is hospitalization required during
Mm.
all stages of treatment?
That's a great question. So with the BFM backbone type of therapies, usually hospitalization is only required for that first 4-week induction phase. And then for the subsequent phases, we do them outpatient. There are some institutions I've heard that will even discharge patients a couple weeks into their induction. So you're really not hospitalized for much of it. I think it's sort of a mixed blessing for patients, though, because the subsequent phases can be really, really intense. And on some weeks, for instance, of that second course of therapy, that consolidation course, patients are coming in to get treatment 4 days a week. And that's a lot. So, coming back, for some patients, coming back and forth 4 days a week is not better than getting to sleep in the hospital and not have to trek back and forth. But in general, for those pediatric regimens and pediatric inspired regimens, most of it is not in the hospital. For hyper CVAD regimens, usually you're admitted for a few days and then you're discharged from the hospital to recover from the treatment. So it's short hospitalizations for each course of those treatments. One thing that I will point out is that blinatumomab, I didn't go into this in detail, but anybody who's been familiar with it, blinatumomab, one unique thing about it is that it's delivered as a continuous infusion over 28 days, meaning that patients carry a bag of the drug with them at all times, and it other sort of port or Hickman catheter, these central lines that we give to most cancer patients. And so that does require a hospitalization almost always when you initiate the treatment. Some institutions will admit patients for the beginning of the first 2 cycles depending on how people react to the drug initially, it can be just a few days up to a week or more. But then patients have to carry around a bag that gets replaced every 7 days for 28 days at a time. So it is a bit of hassle in that regard, especially for kids. I will say patients feel really good on the drug usually, and they appreciate it afterwards, even though carrying a fanny pack with drug infusing is challenging. And there are there are several trials looking at versions of blinatumomab that are given less frequently, so it doesn't have to be this continuous infusion, but that does have the currently FDA approved version of this type of drug does have some particular challenges.
Thank you. Yeah, I think that
Mm,
makes things into a different perspective. Thank you a
mm,
lot. And
yeah,
I think that's all the time we have for questions. So once again, thank you a lot for that amazing presentation, for helping us kicking off this event, hopefully the one of many. So once again, thank you for your time. We appreciate it a lot. I invite the rest of the audience to stick a little bit
thank
with
you.
my ending slides. Yeah, thank you. So before we officially wrap it up, I just want to take a moment to thank again everyone for joining us. And as you leave the webinar, we would really appreciate you taking 2 to 3 minutes to fill out a really brief survey that will pop up. It's your great chance for you to share your feedback, to share what things truly matter with you, what you want to learn, what we can do better. And since this is our very first webinar for the ALL community, we're still trying to coordinate dates for upcoming sessions. That said, I can tell you that the next topic would be making sense of lab and genetic tests in acute lymphocytic leukemia. So we will learn a little bit about what the labs mean, what they truly mean to us. And we don't have a date confirmed yet, but because you registered for today's event, you will automatically get an email as soon as registration opens, so you won't miss it. And since we're just getting started, we'll have your input on what topics matter the most to you. So please let me know that on the survey. Also, if you're interested in other types of support, HealthTree is hosting in-person events, which I will talk a little bit later on. And we also have a different type of event. We have financial education for blood cancer patients. And this might be helpful for some of you. The title is Avoid Medicare Advantage Traps and Medicaid Eligibility Pitfalls, and it's designed for all blood cancer patients and their loved ones navigating healthcare coverage. We know this won't apply to everyone, but if you think this information could benefit you somehow, we'll love to see you there. If you want to learn more about any of these events, don't hesitate to reach out to our amazing support team at support@healthtree.org. And speaking about in-person events, so this year we're planning on visiting many communities. Connect to Cures is a free in-person event where you can connect with other patients, you can learn from local doctors, you can also discover key resources with our HealthTree team. We already started earlier in June with Macon, Georgia. Then we went to Peoria. We'll go to Orlando next. And from then, we will go to Harrisburg, Virginia, Fresno, California, and so many other places. So if any of these cities are closer to where you live, we would be happy to see you there. If you have any questions, please do not hesitate to contact us. You can save your spot by scanning that QR code. And before we wrap it up on now, I just want to say thank you from the bottom of my heart for being part of this very first webinar for the ALL community. We know how isolating this journey can sometimes feel, and we hope that this space becomes a place where you feel informed and supported. So I left here my email. If you need anything, please don't hesitate to reach out to me. I'll be ending the live stream and recording, but if you like to stay on the call, I'll be here. Thank you again, and I hope to see you in another webinar soon.